Hello everybody, my name is Abhay Srinivasan. I'm an assistant professor of clinical radiology at Children's Hospital of Philadelphia. Very much appreciate the opportunity to speak to you today about the imaging of vascular anomalies. So our learning objectives for this talk, number one, to appreciate an overview of the 2018 ISFA classification of vascular anomalies, and number two, to understand important features of the major categories of vascular anomalies on this classification that you would see on ultrasound and MRI. So with vascular anomalies, the one important feature that you should look for is that you will see more vessels than expected. The vessels may be arterial, they may be venous, they may be lymphatic. So the ISFA classification, the website is given here on the slide, was instituted to standardize terminology and the classification of vascular anomalies, and initially started in 1992 and has been progressively refined. So the vascular anomalies are categorized into two major sections. One is vascular tumors, the second is vascular malformations. With vascular tumors, the key feature is that there is a tumor substance or a stroma to it. With vascular malformations, you will have a primarily vascular lesion without stroma to it. So that is a key determinant on imaging when you're trying to make your diagnosis. Let's start about vascular tumors first. So ISFA classifies these into benign, locally aggressive, and malignant categories. And in the benign category, we have hemangiomas, which are the most common vascular tumors. These are subdivided into infantile, congenital hemangiomas. And under congenital, we have two subsets, which is the rapidly involuting congenital hemangiomas, called the rich, or the non-involuting congenital hemangiomas, otherwise known as niche. So the clinical history plays an important role in diagnosis. With the infantile hemangiomas, the red line, you will see a rapid growth after birth. The lesion is not present at birth, but will grow rapidly in the first few months of life and then slowly involute over the next few years. With the congenital hemangiomas, the lesions are present at birth, so you will see it when the baby is born, and then the diagnosis differs based on what happens to the lesion, whether it involutes rapidly in the context of a rich, or doesn't involute in the context of a niche. And these are what hemangiomas look like. You can appreciate there is a varied appearance on them, and the variation is basically dependent on how extensive it is and how superficial it is. So large superficial lesions are much more visible than the smaller deep lesions would be, and the skin color also plays a role in visibility of these lesions. On imaging, on ultrasound, you will see a very lobulated, mildly hyperechoic lesion. There may be some heterogeneity in the parenchyma and the stroma due to the vasculature. On color Doppler imaging, you will see profuse vascularity, and when you interrogate the spectral waveform, you will see low resistance arterial flow. So these are all classic features of hemangiomas on ultrasound. On MRI, what do we see on these benign lesions? Well, on T2-weighted imaging, the lesion is hyperintense, and on post-contrast imaging, the lesion will enhance completely, and there are important features on spin echo imaging here. Number one is that you get flow voids within this inner central portion of the tumor, and then the margins of the tumor are lobulated, supporting the fact that this is a benign lesion. So let's move on and talk about the other types of hemangiomas. So this is an 11-year-old with a periorbital lesion, and this is not a very young patient, as you can tell. And then on T2-weighted imaging, you see it very bright, extremely bright, which is a classic feature of hemangioma, and there is complete enhancement. On post-contrast imaging, avid enhancement. So what are the next steps here? The next step here would be to characterize this on ultrasound, because ultrasound and MRI are often complementary of each other in imaging vascular anomalies. On ultrasound, the appearance again shows a lobulated margin, and the lesion is hypoechoic in this case to the surrounding tissues. On color imaging and spectral imaging, you'll see that there is low resistance arterial flow going throughout the lesion. And after biopsy, this was diagnosed to be a non-involuting congenital hemangioma or a niche, but the overall features were benign here on imaging. So this is a congenital hepatic hemangioma in this baby. You can appreciate this enormous tumor coming off the left lobe on this coronal T2-weighted MRI. On ultrasound, you can appreciate how vascular this lesion is. The interesting thing about this patient is that on follow-up, about 18 months later, the lesion was completely gone without any intervention. So this is a rapidly involuting congenital hemangioma. Let's move on quickly to the other types of vascular tumors in the locally aggressive or borderline category. The first is a caposiform hemangioendothelioma. These lesions are large and infiltrative. They are very vascular tumors. Most of these lesions are congenital or they occur in the first few years of life. The majority of caposiform hemangioendotheliomas show this thing called Kasabach-Merritt phenomenon, characterized by high D dimers, low platelets, and high PTT, so it's a coagulopathy. And large caposiform hemangioendotheliomas, because they're so vascular, can result in high output heart failure. What do these lesions look like? So this is a 1-day-old with heart failure and consuming platelets, so it has this consuming consumptive coagulopathy. On the MRI, you can appreciate how enormous this lesion is. This is a head and neck lesion with lots of blood vessels, and you can appreciate on the axial imaging how infiltrated the margins are with numerous flow voids on the spinaco sequence. So this is a caposiform hemangioendothelioma. This shows you a spectrum of the caposiform hemangioendotheliomas we've seen in our hospital. Often these lesions are in the extremities, often they're in the head and neck, but they have this infiltrative pattern. They can be pretty massive and they can be pretty debilitative. They can cause a lot of pain and disability. Let's move on and discuss other types of these vascular tumors. Intramuscular hemangioma is one of them. So this has been renamed intramuscular hemangioma capillary type, but may be renamed further in upcoming classifications. These can occur in the extremities and in the head and neck. They are aggressive lesions but benign and can certainly look like a sarcoma because they can have this appearance of infiltrating the muscle. So this is a forearm lesion initially you're seeing here, and you see intramuscular hemangioma, a separate patient with the lesion in the muscles of the calf. And the patient with the forearm lesion had a MR angiogram, which shows this profuse vascularity here going through the lesion. You can appreciate exactly how hypervascular it is. So this is, again, the intramuscular hemangioma capillary type. Another subtype of vascular tumor that you might come across is fibroadipose vascular anomaly. These are painful tumors consisting of abnormal veins and fibrofatty stroma. On ultrasound, you will appreciate vessels going through the lesion and this hyperechoic fibrofatty stroma surrounding the lesion. And on MRI, you'll see often these wisps of fat going through the lesion. This lesion is also, just like the previous intramuscular hemangioma, a lesion that occurs within the muscle, but the difference is that it is not usually a very fast flow malformation. Usually it has predominantly venous supply. On this topic, we should discuss also P10 hamartoma of soft tissue. This is associated with the P10 tumor syndrome, and these lesions also occur in the muscle. And the difference is that they don't have a lot of fat in them, as you can see on this T1 weighted image. They do show enhancement because they are vascular, and the ultrasound appearance is relatively nonspecific, but they do tend to have a mix of higher flow vessels than the fibroadipose vascular anomalies, and tend to look different from the previous two lesions I described. The P10 hamartomas need not look like that. Sometimes they're very massive and they have a lot of flow in them, as we see on this angiogram. You see this very large mass occupying the thigh with a lot of arteriovenous shuntings, but this is also a P10 hamartoma of the soft tissues. So we've discussed a quick overview of vascular tumors. We'll move on to vascular malformations. So first in vascular malformations are lymphatic malformations. These can be either macrocystic or microcystic, and they wax and wane clinically with viral infections. They can also enlarge acutely with hemorrhage and infection. On MRI, these lesions show septal enhancement only. On ultrasound, they show discrete cysts without internal flow. So these are some characteristics ultrasound images of macrocystic and then microcystic lymphatic malformations. On MRI, you have a T2 hyperintense focus here, and on post-contrast imaging, they show only septal enhancement. So this is lymphatic malformation. With venous malformation, you have malformed and malfunctional veins comprising the malformation. On MRI, you see serpiginous channels. One important feature is that you do not see flow voids and spinnaco sequences. You see enhancement of the lesion in venous phase as opposed to the lymphatic malformation where you only see septal enhancement. And sometimes you see phleboliths. On ultrasound, it's a similar picture. You can see this lace-like spongiform lesion. Sometimes you see serpiginous channels, although they do not form cysts. The Doppler may or may not detect flow, but usually it does detect some slow flow if you are diligent. And sometimes you see phleboliths as well. A characteristic MR image of a typical lymphatic malformation with a small phlebolith here. On post-contrast imaging, on delayed imaging, you see some central enhancement here, unlike with lymphatic malformation. Typical ultrasound appearance of venous malformations. This is a spongiform venous malformation, shows some sparse flow on color Doppler imaging. And this is a varicosity, a very large axillary vein, varix. You can appreciate how large it is, and there is a phlebolith within a different component of this malformation here. So you have one appearance where it's spongiform, another where it's just dilated and ectatic here. Some characteristic features on ultrasound. Extensive venous malformations can look like this, where you have a lesion infiltrating a good portion of the thigh, like in this case with the vastus medialis muscle. The important feature here is that there are no flow voids on spinnaco imaging. And on ultrasound, you can again appreciate the small channels going through the muscle in this patient. The muscle itself does not show normal architecture. It's more hyperechoic than normal. This is a case with what we call Bockenheimer phlebectasia, where there's marked venous malformation occupying a huge portion of the body. And this is the time-resolved MR sequence here that shows how delayed the contrast enhancement is relative to the arterial phase, but these venous lakes are so large that they enhance reasonably fast compared to smaller venous malformations. Quickly on arteriovenous malformations, these are basically short-circuit connections between the artery and the vein. The important features here are that you will see flow voids on spinnaco imaging, you will see enhancement arterial phase and early draining vein on MRI, but there is no tumor stroma. On ultrasound, you will see fast flow with low resistance. So this is a characteristic MR appearance where there is tumor stroma, but they're just vessels, but no tumor stroma within the lesion. The lesion completely enhances. And then on this maximum intensity projection of your time-resolved sequence, you can appreciate an early draining vein coming off the nidus. So this is a sign of AV shunting. Another arteriovenous malformation of the breast, you can see flow voids within the lesion and then peripherally some slower flow of blood vessels, but this is certainly an arteriovenous malformation given the flow voids and the lack of tumor stroma. On ultrasound, you can appreciate the lack of tumor stroma, and there is very low resistance but fast flow going through the lesion on ultrasound. So on imaging recap, this is a good diagnostic algorithm to keep in mind. If you have a lesion and there are too many vessels, you should certainly think about a vascular anomaly. If there are not too many vessels, think of something else. Coming down, is there a tumor stroma here? If there is a tumor stroma, then you should think of a vascular tumor. If there is not, think of a vascular malformation. On vascular malformation, if there's flow voids on spinnaco sequences, think of an AVM. If there are no flow voids, think of a slow flow lesion and differentiate these based on internal enhancement into either a venous malformation or a lymphatic malformation. And a quick recap on our tumors that we discussed. For infantile hemangiomas, you can keep in mind that it goes away slowly, but it's present only after birth. For Non-involuting congenital hemangiomas, it presents at birth but never goes away. For rapidly involuting, it's present at birth but goes away fast. For the borderline aggressive tumors, caposiform hemangioendothelioma are infertative and show Kasabach-Merritt phenomenon. The intramuscular hemangioma capillary type are very vascular and they're in the muscle. FAVAs are also in the muscle, but they show fat and they're less vascular. The P10 hamartomas, they have mixed vascularity. More of them are high flow, but they are often also in the muscle and the soft tissues. One thing to keep in mind is that with borderline tumor, sarcomas would be in the differential diagnosis. Again, quick overview of the vascular anomalies and the diagnosis of them. Thank you very much for your consideration and time.